Hi, welcome back to Hill and Ponton's video blog. I'm attorney Allison Reddick. I'm here once again with our special guest, Dr. Al Vanitas, a compensation and pension examiner, C&P Examiner for short. We're glad to have you back, Dr. Vanitas. How are you?
So great. Fantastic to be here. Thanks for having me back on.
Of course, absolutely. Your expertise is just amazing for us to be able to pick your brain and ask all of the questions that we need the answers to. So today we're going to be discussing two major mental health conditions that often get confused for each other. Those are anxiety disorders and PTSD. So how do you differentiate between an anxiety disorder, and I know there are multiple anxiety disorders, so we can go into that as well, and PTSD? What's the big differentiation between the two?
So, yeah, and that is a question I get a lot of times too from veterans. So, post traumatic stress, in essence, is under the umbrella of anxiety. It is an anxiety disorder. Anxiety tends to overlap into a lot of other different types of diagnoses, but the symptoms do start to differentiate themselves a little bit when you get a little deeper into each diagnosis.
So are there sharp differences between the symptomatology? I know a lot of people, when they think of anxiety, they think of panic attacks, but I mean, that's even a separate disorder on its own. But when I would think the general public thinks of anxiety, they think of elevated heart rate, sweating, feeling anxious and really jittery, things like that. I mean, is that an accurate representation, or what are the distinct symptoms for each of the disorders?
Yes. So some of those physiological symptoms you were talking about, they coexist in all the anxiety disorders. So this is the heart racing, deep breathing, shallow breathing, racing heart, sweating, or even racing thoughts can occur during anxiety, and feeling keyed up or on edge. That's another one that kind of plays a role in all the different types of anxiety disorders. When we look at them individually, and there's a few, I'll go through the main ones, which are generalized anxiety, obsessive compulsive disorder, PTSD, and adjustment disorder with anxiety. So generalized anxiety is exactly what it sounds like. It's very generalized. So it's anxiety about everything. It could be about the ozone layer, or the work I have to do tomorrow, or how am I going to get the kids to school? How are we going to pay these bills? Where when you look at something like post traumatic stress, it's usually much more specific to cues in the environment that kind of trigger the anxiety. This could be like loud bangs, flashes, smells of things. A generalized anxiety would be more about everything and wouldn't need to be triggered. Obsessive compulsive anxiety is usually, it could be related to like contamination, like things are dirty. My hands are dirty. I got to keep washing them to lower the anxiety. Now, you will see each of these play a role in post-traumatic stress. Like I said in the last video, that post-traumatic stress will present like all the others. So you could have panic attacks because of post-traumatic stress and not necessarily meet the criteria for panic disorder. You could have obsessive compulsive disorders with PTSD, counting out how many steps between where your gun is. The obsessions and the compulsions become about safety and hypervigilance.
So basically, it seems like these conditions are very similar, but when a C&P examiner is asked to look at a specific mental health condition, there's a separation between mental disorders and PTSD. PTSD has its own DBQ, disability benefits questionnaire. So what differentiates the two? Is it a specific stressor? Does PTSD require a stressor, whereas the other anxiety type disorders don't?
That's correct. The other anxiety disorders could be genetic. If somebody in your family, if you have OCD, somebody in your family has that type of anxiety. If you have panic attacks, Even suicidal thoughts we can trace back genetically. Somebody in the family had that level of depression. But when we look at post-traumatic stress, there, and I'll tell veterans, there's likely no family history of this unless like you had an uncle in Vietnam or Korea or something like that, which the stressor events are what cue the PTSD and make it different from the anxiety disorders.
So, for a stressor, how do you differentiate for PTSD whether a stressor meets the criteria for a PTSD diagnosis? What are the requirements?
And this is a good question too, because it really does involve actual or threatened death, serious injury, physical and or sexual violation. And now when we talk about threatened death, this is where the line gets very tricky, is when let's say you have somebody and they're an army soldier and you have your whole unit is against you and you're overseas, maybe you're not in a hostile environment. Maybe you're just on a ship or something like that. But the others around you, the threat of death is there. They're telling you, like, you better watch your back. We're going to throw you over the ship, things like that. To where, no, do they actually hurt you? No, but it was still the threat of it is there. That's where the line of this becomes difficult. But if it's anything where you observe something, witnessing training in motor vehicle accidents, those can all be stressor events. And there's a couple that I wanted to go through with you about, talking about how stressors meet criteria for PTSD. So a stressor, let's just take a look at threatened death. Okay. I'm going to show combat versus non-combat. So I did have a veteran who was, he was an Iranian captive. He got captured by the Iranian military. He put a bag over his head. They're speaking in different languages. He's thinking over the next 16 hours, this is probably not going to end well. Every once in a while, he might take a punch in the face or get hit with a firearm. But eventually, it was worked out and he was let go. When it came back, the raider asked me, like, well, this person didn't really get shot. It's not like they got hurt. I'm like, no. I mean, other than a few lacerations to the face, but over 16 hours of thinking you could be beheaded, they might just set you on fire.
Mhm.
That's pretty traumatic, even though nothing actually happened to where you would think, it would be a traumatic event. That in itself, the threat of that death would be considered a traumatic event. Another one I want to share with you that's non-combat related was a pilot that was on leave. He was flying home over the Atlantic Ocean with his mother. And I'm not sure if I went through this one before with you, but he's on leave. Okay. We're not in combat. We're back here stateside. He's a Navy pilot. The engine fails, the plane goes down in the middle of the Atlantic Ocean. Now, you're with your 65-year-old mother, and now you're in the middle of the ocean and he has to abandon the plane and figure out a way to get mom back to shore. Can't even see shore. So he's got to get on top of the plane just to jump and look to see if he can find a horizon to get to shore. Several, maybe 100 miles away. And so he's drifting, swimming. Long story short, mom does not make it. He eventually does make it and is so dehydrated and he has to be hospitalized for a week when he gets back. So again, did that involve combat? No. Did he experience death himself or was he shot at? No. But that's still an event to where you could see it involves actual threatened death, serious injury, and things of that nature.
And in that second example, I think it's important to understand that even though he was on leave, he was still an active duty soldier. So even though that flight had nothing to do with his military duties, he was still active duty, so that counts. So
Oh,
if a
100%.
yeah, if a veteran is in a car accident going home from base, that counts. If
Bar
you're active
fights.
duty, exactly, anything counts. And then going back to your first example, I mean, I think both of those are very extreme traumatic incidents, but I think that even lesser incidents would also be considered fear of hostile military or terrorist activity. And that's something that was added to the criteria area. The example I was thinking of would be I have a lot of veterans who they are members of convoys overseas and they don't actually get attacked, but they see the bombs, they hear about the gunfire, they have to clean up the vehicles that have been covered in dead bodies and firefight and things like that. I mean, that's something as well that would count as a PTSD stressor, correct?
Oh, absolutely. Anytime you got to clean up the remains of situations or just the threat. I mean, just we're going to go through this area. The likelihood of us making out of here is 50-50. That in itself, knowing that, and then you see the hostiles around you, all of that. And it can even be to where you feel like you need to act like, there's a barge heading to you and they don't speak English, but you're telling them to stop. And eventually, like if you're doing all this and they're not, eventually now you're getting on some kind of turret, getting ready to fire at what turns out to be just a whole family of people, and they just didn't know what was going
Mhm.
on, but you almost pulled the trigger.
Mhm.
I mean, stuff like that. There's all types of situations that involve the threat of death or just the aftermath. If you're witnessing the aftermath of seeing a little girl holding a doll and it reminds you of your 8-year-old back home, I mean, those are certainly post-traumatic events. Absolutely.
Do you have any examples of stressor that wouldn't qualify under criterion A for a PTSD diagnosis?
Yes, there are injuries that aren't severe. When we're looking at things that are not serious injury, like if you trip and fall, that is not a serious injury. Many times the harassment of the military is considered post-traumatic, and that this
Mhm.
is where the line becomes really tough because no, people are not going to be nice to you, and the weaker that they see you, I mean, there's a lot of victim blaming in the military. So if something happens to you, it's like, what did you do? Those are the kind of situations where it can be where, yeah, I mean, they were picking on you a little bit or harassing you, but if you weren't getting beaten or threatened with death, then name calling and things like that, even sometimes crossing the boundaries of things that people say verbally does not quite count as a post-traumatic event. And I mean, that could even count as racial or sexist remarks. I mean, very offensive, but not traumatic enough to fit into this type of a category.
I think it's also important to say that it's really a case by case situation. I mean, there's one situation where it's like, oh, well, I heard about this person who passed away. They were on this flight and I could have been deployed and that could have been me, versus I was scheduled to get on that flight and something happened and that flight went down. Would that be considered PTSD? That fear of that could have been you?
Yeah, for sure. That's one I've heard a bunch of times. I've even having that happen to my own family member where he was on the flight and a higher ranking officer says, "You're getting off this plane." And he says, "No, I'm not. I'm going home to my family." And he says, "I'm a higher ranking officer and you're getting off this plane." And he gets off the plane, and as it's taking off, the thing crashes and burns. So yeah, that absolutely would be considered a post-traumatic event, or events where you should have been there and you were late and a sniper took out some people, or just had a bomb, and then killed your unit or people you were with. It could have been you. Or another one on the lines of what you're talking about is, guys that were like scouts and they're relieved of their duty, and then the next guy that goes out in that spot that he would have been running that mission, that person goes down. And so then you start thinking, well, maybe I didn't prepare him enough. I should have probably told him about, you start really starting to question. And so, yeah, those can too, but you're absolutely right. It is a case by case. What's traumatic, like I say, to one person might not be traumatic to somebody else.
So there are a variety of stressors that can lead to a PTSD diagnosis. And sometimes when I'm reading C&P exams, they'll meet criterion A because of fear of hostile military or terrorist activity, but then they'll only meet like a few other of the criteria. They won't meet the avoidance, or they won't meet something else. Like one of them's missing. And is that common? Because I feel like if you have that first stressor, you're most likely going to have experienced those other symptoms at some point. And I mean, some people experience some sort of symptoms and some don't experience those same symptoms. It seems like, okay, if this person has all of these symptoms, but it doesn't affect their social situations, things like that, well, they don't have PTSD. I see that a ton. How common is that?
Yeah, I see that as well. Now, the legitimacy of it is a little dicey because if somebody is missing a few pieces, that is rare. Usually at some time they have those pieces. And I'll usually tell them, I'm seeing you in a snapshot of time here.
Mhm.
So this stuff roller coasters. So, and I'll say to especially some of these older guys, like if I were to look at you in 1980, how would this stuff be playing out? Versus now, that you've had some time to deal with it, but there's still you can see a lot of symptoms there. But I do see every once in a while where there's a piece of it, but just not the whole thing, like where they're not really that hyper vigilant, or they don't have the exaggerated startle. They might have the anger, they might have nightmares here and there, but there's bits and pieces, but just not enough. That happens once in a while where it's like an other specified trauma and stressor related disorder type of diagnosis, but I'd say the majority do meet the full criteria of post-traumatic stress.
And that's what I wanted to move on to next is that's the unspecified stressor or other trauma disorder, as well as adjustment disorder. I see those a lot as well. When the examiner shows that the veteran doesn't meet criterion A, they don't meet that stressor, they say something happened, but it doesn't meet the criterion for PTSD. And then they give these other two diagnoses. Can you give us a little more depth on these diagnoses? Are these anxiety disorders as well, or are they on a different spectrum?
Yeah, they are both anxiety disorders. Adjustment disorder is, I would say, the absolute weakest anxiety disorder you could have. In the old DSM, there was a specification between chronic and acute adjustment disorder. That does not exist anymore. However, the VA still holds on to chronic or acute adjustment disorder. And realistically, this type of anxiety is like a kid starting a new school or a new job, having problems fitting in. Those are the kinds of things for adjustment disorder. The other specified trauma and stressor related disorder, that's going to be that you had a stressor, you have many pieces of post-traumatic stress, but it's just not quite all of them. Or there's unspecified trauma and stressor related disorder. So I try to stay away from those if possible, but every once in a while you will have someone who doesn't fall neatly into the PTSD category.
And I think it's important for us to realize that regardless of what your diagnosis is, they're all rated under the same criteria, which is what we'll get to. But for me, I just was reviewing a case for a woman who was a combat medic in Iraq, and she dealt with dead soldiers and injured soldiers all the time. And the VA says she doesn't have PTSD. I mean, her providers say she has PTSD, but that one C&P examiner said she doesn't have PTSD. She has other specified stressor disorder, which now that you explained it, it seems like at that snapshot in time, she didn't meet every single criteria for PTSD. So that's probably why he or she gave that diagnosis of unspecified trauma disorder, because they're recognizing that stressor, but they're only looking at it in that snapshot of time. And at that snapshot in time, she didn't meet all of the criteria.
That does happen. A lot of those, though, I do get where I see, unspecified depression, adjustment disorder with anxiety. And I'm sitting there telling this person, this is PTSD.
Yes.
All
Yes.
these symptoms, the PTSD is driving this whole train, and all that other stuff is just falling off because it's PTSD. And so The best way I can explain it to them is if we went back in time and took away that in-service events, most if not all this stuff goes away, does it not? You didn't have any of these problems before the service, and it's like, oh well, yeah, I guess so. Well, then now we know that it is strictly related to these environmental factors that occurred.
Do you
Um,
think there's like a fear of overdiagnosing PTSD? I mean, I just feel like if a veteran was in combat and experienced these traumatic events, they have PTSD. Why are they giving all of these other diagnoses?
in the beginning, I didn't, I just looked at it for what I just thought, maybe people were making mistakes. But then I started to realize it doesn't look good if you're a veteran going to get another job. It doesn't look good if you want to hold a firearm. And it doesn't look good for recruiters trying to bring in new veterans that, oh my gosh, look at this influx of cases of PTSD. The media would be all over it before you know it. Nobody wants to join. So it's like we could find some other ways to break this down without using that word. You know what I mean? So I do believe that's a thing. For whatever, that reason seems like it could be logical, but I don't know for sure. But I'm with you. I find a lot of cases that are coming in as other stuff, and it's post-traumatic stress. Now I'm having to use another DBQ.
Absolutely. So we've really harped on the PTSD. What kind of situations would an anxiety disorder, like if you were in the service and you were constantly harassed or like racially harassed, is that something that could trigger an anxiety disorder?
For sure. And that kind of stuff could start as like an adjustment that leads to a major depressive episode,
Mhm.
maybe even attempted suicide. It could lead to anxiety that causes panic attacks, things of that nature. There's a lot of OCD in the military as well, obsessive compulsive disorder, which again, nobody does behavioral psychology like the military. And in the beginning, guys are doing things, veterans are doing things that don't really make a whole lot of sense. Like, well, why do I have to make my bed the same way this guy does? What does it matter if my belt loop buckle isn't in the same place as his? But it does matter.
Mhm.
Those are all small microcosms of the much, much bigger picture. If we can't count on you to dot I's and cross T's on this little stuff, what are you going to do downrange where we really need you to hold yourself accountable for everyone's sake? Now, that stuff comes back here. And so orderliness, putting things back is very important. And I don't want to get off too far, but that can also lead to where the anger comes through when things are out of place. A loved one leaves a cup in the sink. It's like, well, why didn't you put the cup back into the dishwasher? And here it's more cavalier, like, well, it's just a cup. It's no big deal. We'll get to it later. And to the veteran, like, no, it's not just a cup. It's a reflection of who you are. You're the kind of person that drops the ball out there and gets me killed because you're not paying attention. So that's where that obsessiveness comes from. Check it again. You don't just cut. You measure 3 times first. An ounce of prevention is worth a pound of cure. So everything is going to be dotted and crossed and done the right way. And that stuff breeds OCD. So most folks that were in the military are going to be extremely organized, or what used to be termed squared away. And so that has led to a lot of obsessive compulsive like behavior, for sure, through the use of classical conditioning. And just to give you an example, the military does it to the soldiers, but it's used on us too. To give you an example, so if I would have shown you this in the year 2019 and said, well, what is that? You would have said, oh, that's one of those
As doctors use.
surgical masks, like,
Surgical. Mhm.
for germs and stuff. I show this to anyone in the year 2021 from 4 to 94, and they know they know what this is. This has
Mhm.
been conditioned. So that's the same kind of principle that goes involved with the veterans and the obsessive compulsive about specific behaviors and regimens.
Well, in the specific behaviors and regimens, I feel like civilians, if you're not in this world, you don't get it. And I feel like a lot of these examiners who haven't experienced it or know the structure of the military and how the intensity of it. I mean, I see so many examiners that are like, well, why didn't you get treatment for that? And it's like, if you're a soldier, you don't go and get treatment. You stay on your duty post unless you're
Right.
dying. And
Yeah,
people
this
don't get
isn't
that.
this isn't sitting around kumbaya. I
Yeah.
mean, the truth is, we have a lot of providers that never played sports or have been in the military or really just been in a fist fight. So most people, the anger and irritability that comes with the body goes into fight or flight mode, and it starts to feel like anxiety or rage to either confront stressors or get away from them. Survival switch, fight or flight response. I've heard it termed a bunch of different things. The bottom line is we're all hardwired with that. The issue becomes bringing that back into the bubble, the civilian bubble, where people here, they are not wired to guard their lives.
Mhm.
People here take their personal safety as an absolute given. There's no looking over your shoulder or scanning parking lots. It's walking around crowds just like this, oblivious, because you've never been given a reason to pay attention to the others. All it takes for this stuff to kick in is just one instance. If a friend of yours, family member walked into a Burger King and three guys come in there wearing clown masks with shotguns and start shooting the place up, they are not going to be looking at the world the same way anymore. You're going to have your head on an absolute swivel out there, So, yeah, I mean, I do feel that is 100% how it plays out.
So, speaking of service connection and things that can be claimed, I see a lot of claims for secondary service connection. So let's say I had a veteran who was in a severe tank accident and he basically has no movement in his neck, very movement in his back, and he developed anxiety and depression. Is that something that he could get secondarily connected?
100%. Depression, this is a good one because depression can come from the injury and the event.
Hmm.
So the post traumatic stress leads to the depression in this fashion. Anxiety causes avoidance. So maybe you used to like to go to concerts or ball games, shopping at the mall. Now it's not worth dealing with that. So you start avoiding, the world gets smaller. You're not leaving your city. You're not leaving your house. Before you know it, it's like to work and back into a room all day. And when that happens, that starts our cycle into the PTSD, anxiety, depression, because things aren't fun anymore. We're not getting that reinforcement from the environment. So that's one avenue to depression, through the environment. The other way is these injuries. You were running 10 miles to cope with stress. You were doing push ups. You were Superman. Now you can't even pick up your little kid. Okay. So now you start to feel inferior. It affects self-esteem. It causes more avoidance with that. And then the anxiety of how's this going to play out? Some 30-year-old guy, like, man, I'm only 32. I got my whole life ahead of me. I can't even hardly walk. What's this going to look like when I'm 60? So that significant loss of not being able to do things socially or occupationally that you were once able to do is a significant contributor to the depression. And that's a whole nother avenue outside of the trauma.
How often are you seeing patients and having to do DBQs for mental conditions secondary to other service connected conditions?
I would say that's pretty frequent. I mean, I did 8 of them today, and 2 of them were related to medical conditions, fibromyalgia and diabetes and neuropathic pain, that kind of stuff due to Agent Orange or neurochemicals. Or sometimes just, a training incident. You jumped on one of those platforms and your knee buckled to where your career got cut short. Your whole plan was to be a career veteran, and now everybody hates you because you're going to the infirmary. Then you come back home and you're looked at down by your family and friends, and just one injury like that started to spark this cycle of depression. So yeah, we see that quite a bit.
And I think that's important to highlight is to get to the point of getting a C&P examination, the veteran has to provide evidence to show that, because of this injury or this physical condition, like you stated, they can't do anything anymore. They can't pick up their kids anymore. Filing statements and things like that will show I never had any mental health issues. I had this accident and I developed these physical conditions, or I was exposed to Agent Orange and now I developed all of these conditions and now I can't do the things I like anymore. I can't pick up my kids. I don't want to leave my house because I just am embarrassed that I can't do anything. That's important evidence to show that this event led to you developing that mental condition.
Absolutely.
So now let's talk about how the VA rates mental disorders. So you have the DBQ and you're checking off the diagnosis and you're giving a history, occupational history, social history, military history. If it's PTSD, you're going through the PTSD criteria, and then you're checking off symptoms and you're saying what level of occupational and social impairment. Now, do you know the actual rating formula that's used based off of your DBQ of how the vets are rated?
No, that
Okay.
I don't know.
Well, so
So
so it's interesting because I know both because I see both. And for me, what differentiates the rating is really what symptoms you check off and what level of occupational and social impairment you check
impairment,
off.
yeah, that right, yes. But I still don't know how that's quantified, but because the social and occupational impairment is broken down into like 5 or 6 categories, and
Mhm.
some people kind of fall like in a half zone, you know? I mean, it's not that cookie cutter. I try to get it as close as I can. There are some things that help to make the determination, or that helps the VA make their determination.
Mhm.
So past records is huge. If you can show that you were, 82nd Airborne, you did 120 jumps, and now you have knee problems that have also been documented and have been treated while you were in the service, that's kind of a slam dunk.
Mhm.
If you have letters from friends, like with PTSD, buddy statements about your behavior, family, even friends that once knew you, that how this person changed, the VA does put a lot of weight on those as well. And of course, the history of employment. This is somebody who was a workhorse their whole life, because most of the people that go into the military were hard workers. They got past the entrance exam. Now, this is a person that's lost 6 jobs due to outbursts or memory and concentration problems on very simple procedures, having trouble making it on time. Those are also records to help. And then, of course, mental health history. If this is somebody that never had any mental health problems and now there's documentation of being Baker acted, or anytime there's an STR, a service treatment record, I always say that makes my job a lot easier. When they've already treated it in-house, it's like, so that those are the kinds of things that do make it a little bit easier.
So I kind of want to go through the criteria and maybe you can give an explanation of what kind of symptoms or impairments you would see relate to that rating. So personally, I rarely see a 0% rating. Basically, what that is, it's a mental condition has been formally diagnosed, but symptoms are not severe enough to interfere with occupational and social functioning or to require continuous medication. Are you ever seeing that where you're diagnosing mental condition, but there's no symptoms?
I've never done that.
I've also seen where they'll give symptoms, but they won't diagnose a mental condition. They'll say that there's not enough to provide a diagnosis for a mental condition.
I'm with you. I feel like I'm not sure what the barriers are that keep providers from going into more detail or being more thorough with that. But I can tell you, when I get those, the ones that I feel like, I'll be completely honest with you. Sometimes I see a report and I'll look at it and be like, the last person, did they even do this with you? Did they even ask you any questions? Then I
Mhm.
start interviewing them about the interviewer. Like, okay,
Yeah.
what exactly did you do with that provider? And they're like, well, it was like 10 minutes. They just looked down, typed a few things, and I was at, do you want to hurt yourself? Oh, great. Okay, see ya. So, I mean, if I hear that kind of stuff and the report reflects what the veteran's saying, I might even make a comment about that, like tactfully, but to let them know, I mean, come on, this is a guy with two Purple Hearts and you're telling me he's getting 8 hours of sleep every night? Come on.
Right.
So I mean, some of it is a little outrageous. I can say this, it seems to be getting a little better over time, comparative when I first started seeing some of the reports that were done. But if you have symptoms, there's something there. Even if you have just some mild depression, okay, then that's at least an adjustment disorder with some depression or an unspecified depression. I mean, there's something. So to have symptoms and not have a diagnosis doesn't make sense to me. And to have a diagnosis and you're telling me it has zero level of impairment, well, then that also doesn't really make a whole lot of sense to me either. Because without the diagnosis, this person would be able to do something a little more efficiently, sleep, be around people,
Mhm.
so public speak. A lot of people don't like public speaking.
Or interact with people, strangers. Don't
For
want to
sure.
interact with anyone. They don't
And
even want to interact with
that's
their own family members.
the post-traumatic anxiety, that is what creates that detachment to humanity, which is, yeah, it's with other anxiety disorders, but with PTSD, for somebody that was social and gregarious and captain of the football team, and now this person doesn't want to leave their house or can't even stand in line at the grocery store, clearly an event happened which changed all that. And I try to make that clear to the veterans too. I'll say, shopping at Publix when you were 15, 100 people behind you, no big deal. Now that's going to be a lot different of a situation. And so once they start to be able to see that too, they start to understand, like, oh, that's what that is. I just thought I was like, losing my mind.
Absolutely. I don't really see 10% that often either. It's occupational and social impairment due to mild or transient symptoms, only during periods of significant stress or symptoms controlled by medication. So I know for like hearing loss, when they do the audiogram, it's supposed to be without hearing aids if they have them, how their hearing is. So when you're assessing someone's mental health conditions, is it when they're on medication or is it when they're not on medication? Because there's a big differentiation between those two.
For sure. And if they're on it, I will ask them, what would this look like if you were not on it?
Gotcha.
Now,
Okay.
most of them won't take it, or they'll tell you they're taking it, but they're not taking it, or they are taking it and they're having a lot of side effects. I mean, to a normal, healthy brain, those psychotropic medications are going to cause a lot of side effects.
Mm-hmm.
And the truth is that post traumatic stress doesn't really have a whole lot to do, pretty much nothing to do with neurochemicals in your brain. It's not like there's not enough serotonin and, oh, this fluoxetine and this sertraline is going to fix it. What that all that's going to do to the male brain is flood it with more serotonin and cause sexual defects and dry mouthedness and grogginess and feeling like a zombie. I will say providers have been trying to medicate away experiences for a long time. You cannot drink, drug, or medicate away an experience. Once you've actually been there and seen it for yourself, it's not like, oh yeah, just take this pill, you'll be fine. I mean, don't get me wrong, those meds can knock down the intensity of symptoms a little bit, but starting the treatment with a bunch of meds, I highly disagree, especially with people that never had mental health problems. There's people out there that really do need those meds that are clinically bipolar. I mean, they just don't have enough of those neurotransmitters. Okay, that I can understand. But somebody like you or I that has no history of mental health, and then all of a sudden we start exhibiting significant symptoms that meet the criteria for a diagnosis like a post-traumatic stress disorder, medication would not be the route to go.
Mm-hmm.
I would say with the meds, maybe an anxiety, like as needed if you were going to be like in a crowded airport for 3 hours. But I do feel like the meds are overdone for sure.
Oh, yeah, absolutely. Moving on in the criteria, 30 and 50%. I see those a lot. Lots of reduced reliability, depressed mood, anxiety. Those are the suspiciousness, Those are the symptoms that I've always seen checked off. So they're pretty safe ratings. But moving on to 70 is where you're having that near continuous panic or depression, you're having that unprovoked irritability, and you're having suicidal ideation. So suicidal ideation is a huge red flag for me. And I know we've discussed this before, but just to reiterate, well, I have veterans who, even if it's passive, they're scared to tell examiners about their suicidal ideation because they're afraid they're going to get hospitalized.
Yeah.
How do you approach discussing this topic?
That is one I heard today, actually, where a guy, he wanted to go down the road of it, and he's like, "How much can I tell you without being hospitalized?" So I kind of laughed at that. I said, "Here's the thing with suicide," and I try to put it out there for them how I'm seeing it, to open up the door to let them know who they're telling about their thoughts of suicide. So I usually say something like, listen, we all come to some sort of a point where we might feel like, it'd be a lot easier. There's a lot of difference between what would it be like if I wasn't here versus I actively want to do something. And then I'll say there's a big difference between thought, plan, and intent. But it is all about intent. I mean, I could give you a good plan about how I might rob a Brinks truck. I think we talked about this, but it doesn't mean that I'm going to follow through with that. But I think we all at times walk through our minds certain things. So now that kind of opens up the door to be able to say, like, well, yeah, I thought about it, but I don't have a plan. Or I've had people say that they've attempted before, but it's been a long time. Now, once I get to that level, then I start assessing for the level of their environment. Like, well, what do you do when things start to go down that road? And they might say, well, I go for a run, or sometimes I'll talk to my wife, or it's my kids that keep me from doing anything like that. I try to keep busy. And so then after they tell me what they do, I'll offer some things like, have you tried calling the veteran crisis line? How has the outpatient therapy been going? I encourage them to get back into that, or have somebody to just do maintenance therapy with, even if you don't want to do it continuously, just to prevent it from getting to that kind of a level. But yeah, suicide is a tricky one, because that's the first thing most people usually say to me is like, well, I don't want to be hospitalized, or you're not going to Baker Act me, are you?
Mhm.
And I can understand that. And I try to let them know I am not here to make life any worse for you. For me to Baker Act somebody or hospitalize them because of thoughts of suicide, it has to be pretty imminent that this person is going to do this and they're determined to do it. And I'd say that's extremely rare. Most of these folks really do want to live.
And then 100% rating. As the examiner, you're checking off symptoms like persistent delusions or hallucinations, grossly inappropriate behavior, persistent danger of hurting self or others, intermittent inability to perform activities of daily living. How often are you seeing veterans expressing those symptoms?
That's when we're getting severe.
Hmm.
When the wife is having to dress you and shower you, pay all the bills, basically just day-to-day living. That's yeah, those are pretty severe. The thoughts about suicide that require somebody to be with you almost 24 hours, not being able to hold any kind of work position. I do see it on the severe level to that. I mean, sometimes, people will scream and shout, have flashbacks in the office. They'll get extremely angry to where they can't even sit or come in the office. So that you gotta use some other methods when that happens. It's an interesting thing with how I explain it to others in our practice working with them. You're going to get a lot of cupcakes, which are people that have symptoms, but you're going to get some that are absolutely unhinged. That this person, I need to get him out of this office as quick as possible. You need to go home and just, we need to get treatment inpatient immediately. And usually those people are with somebody else. I would never let those people leave on their own. But the others around them already know this person cannot come into a building like this and meet with people. So, I'd say that might happen 10% of the time. 10 out of 100 are going to be severely difficult to work with.
How common is the psychotic feature of PTSD, having delusions or hallucinations?
That's a good one. That's severe PTSD at that point. When your mind starts to create images and sounds of things that aren't there as almost like a dress rehearsal to prepare if what if they were there, that's a hypervigilance that is at an extremely exaggerated level. And the truth is, we all have that capability, but we're not so hyper vigilant that our mind is staying that many steps ahead. But yes, I will have people that hear their name being called, continuously think they're seeing something on their cameras, because sometimes they'll have their camera, on their phone and looking at their phone. I think I saw something. They could go out there and do a perimeter check. That happens. It's rare where it gets to that level, but it does happen. I mean, some folks even have a genetic predisposition for schizophrenia, and then you're in a bunker and the four guys you're with playing cards with get shot and you're just sitting there looking at them all and you're the only one that lived. That kind of stuff can really kick in the psychosis. It's rare, but I'd say that one might be around 5%. 5 out of 100 are going to be experiencing delusions and hallucinations and things like that.
So I feel like we've talked about a lot of triggering symptoms and scenarios. Do you have any tips or suggestions for veterans who are suffering with severe anxiety or PTSD?
Yeah, let's start with before it gets to the crisis. That's where I like to start because a lot of people will say, like, yeah, that sounds good until, and it's like, well, let's start with not getting to that level. Okay, so the maintenance type of things should be identifying triggers to anxiety, sounds of things, smells of things. Some of them you might know. Some of them you might not know until they come to your doorstep. So this could be like, a guy who is an avid surfer and he comes back from a deployment in the desert, comes back to the beach and then hits the sand and instantly has a panic attack because it's the sand and the way it blew across his legs that instantly kind of brought him to his knees. Okay, so there we're identifying triggers and we can slowly, I would encourage doing some of that individual therapy to lower the anxiety to triggers, relaxation techniques, breathing exercises, mindfulness meditation, grounding techniques. Like when you're in the shower, stay in the shower. Don't think about what you're about to do and don't think about things that happened in the past. Try to stay in the moment with the water hitting you, the smell of the soap, work on the senses, guided imagery. These are all techniques that can be used and be helpful. Even exercising if you can do it, go for a walk. Hit the reset button, I say. Try to get away from the environment that you're in, that you're starting to feel like that, and hit the reset button and then come back. Call somebody, a battle buddy, somebody somebody that might be a little bit distant, that's not right in the home with you, that's not going to be judging you and asking you questions all the time. Like, are you better now? Are you okay? Are you okay? Are you okay? Like that's makes people not okay.
Makes it
So,
worse.
I do feel like those things help. I also, believe it or not, animals are huge. Get a dog. The
Mhm.
veterans that have pets, I had a lady tell me one time I do a lot better with the four-legged than I do the two-legged because it's too peoply out here. Too peoply.
Mhm.
That's another one I like to use. And so I do feel like, those kinds of things can help. Having an animal, they're extremely soothing. And it doesn't even have to be a service animal or emotional support dog. It just has to be a pet that is going to be there. A lot of times these pets will wake you up if you're having dreams.
Mhm.
They'll create physical barriers between you and things, objects that they know and sense that you're having anxiety with.
They also create structure in your life. Having something to take care of, and I have to wake up and I have to walk the dog and I have to feed it. I mean, that's very comforting as well.
100%. It gives you that sense of purpose.
Mhm.
Something needs me, and I need that. So those are, yeah, believe it or not, the service animals and the dogs do as good as any of it, really, that I've seen. In crisis, I would get away from the situation as quick as possible. If you're having a panic attack and you're in any kind of public place, especially like a car, pull over or get out of the public environment, go into a bathroom stall if you have to, wait it out, bring yourself back down to baseline. But then after that, it's important to get to what the trigger was. Was it too many people? Was it a smell? You know, you might not know in the moment, but then that does have to be processed for the future. So those are some of the things I would recommend on panic attacks and PTSD episodes. Flashbacks, those are kind of tough to deal with because the truth of the matter is you're not really online consciously to be able to deal with it. If you're having flashbacks, especially at a frequent level, I might even consider doing an inpatient treatment.
In closing, seeking professional help, how can veterans contact you?
Yes, please reach out to me at docv4vets.com. That's DOC, the number 4, V as in Victor, ETS.com.
And you have a podcast as well, don't you?
Yes, you can find it online. Our website is voncareinc.com. That's VON careinc.com. So please feel free to peruse through our website, check out our podcast, and any questions you might have, please let me know. I'm always interested in helping the people serving the country.
Well, I think that's all we have for today. As always, I learn a ton speaking with you, and I appreciate you doing this with us. And for those of you watching, make sure you let us know in the comments what your thoughts are on this new series we're doing with Dr. Benitez and any topics that you would like to see us cover with him or in general. If you enjoyed this video, leave us a like and subscribe so you don't miss our next videos with Dr. Benitez. So thank you so much.
Thank you so much for having me again. I love doing it. And, I hope we can reach and help more people.
Absolutely. Have a good day.
You too.